Welcome to the Health Matters program produced by the Ministry of Health. I'm your host, Alicia Martin. On March 24th, 2023, we observe World Tuberculosis Day under the theme, Yes, We Can End TB. Joining me today on the program are a few persons from the TB division. Let's begin with Dr. Jitendra Mohanlal. Thank you for joining me on the program today, Dr. Mohanlal. Could we begin by you giving us an overview of the TB situation here in Guyana?
Okay, thank you, Ms. Martin, and welcome. So, at the end of 2022, we've had 396 new cases, which is actually 53 per 100,000 incidents. So, we have actually made some strides over the years to reduce the incidence of TB. If you reflect back to 2012, when we actually rolled out all the TB services in the 10 regions, like for detection and treatment, and we utilized the DOT strategy. We actually had 92 per 100,000 in 2012. So over the years, we were able to reduce it, coming down to 53 per 100,000. And I must say that in so doing, we actually achieved two of the goals for the NTB strategy, and that is to reduce the incidence by at least 20% as against the 2015 target. And in 2015, we had 76 per 100,000 cases, right? So we're on the track to end TB in 2030. However, we still have some challenges, like COVID came and derailed the program a little bit. The daily dots, persons are not having daily dots. We still have some struggles in Region 4 where we're not getting the full daily dots, but there are some new initiatives. So Region 10 was able to implement some other initiatives like the video dots, right, during the COVID pandemic. And they are doing very well. And as a region, they've taken the responsibility seriously to actually reduce the incidence of TB. So they're on track to end TB, because in 2011, they had 70 new cases.
I'm happy that I have this opportunity to share actually what we are doing in the region, and that is Region 10. And actually, I am the TB field supervisor there. And we have a program where we call the DOTS program. The DOTS program is the program that was placed there in order to help patients, to help them to complete their treatment, not only complete their treatment, also to help them to understand the treatment, understand when it's time to come to the clinic, understand when it's time for them to do the actually clinic investigation, right? We have 3 tests that we normally offer. We have the tuberculosis skin test, we have also the sputum test, and we also have the chest x-ray that is being done at the clinic to help persons and also to diagnose tuberculosis. The way how we would have sell the services, that helps the patient to have a clear understanding, and in terms of the response, it's excellent because we are well trained, we are professionals. So when somebody is being diagnosed with tuberculosis, we have the first interview whereby you're able to explain to them the duration of the treatment, you're able to explain to them what to look out for, what is to expect. So because of that, remember, for some information, the way how you sell your product, we're able to get an excellent response from the patient. And I must say that the DOTS program is very effective in Region 10. So we don't only do the face-to-face, the house-to-house visit, we also have the video dots because of some person, because of the geographic location. If it's, let's say, a hazard, or let's say for some sort of restriction, you cannot get to the person directly, we also have the video dots whereby you're still able to meet them to help them to complete the course of their treatment.
And I must say Region 10 was the second highest burden region on the Region 4. And Region 4 currently sees 50% of all the TB cases in the country. And as of 2022, Region 10 had just 14 new cases. So they are working very well. They actually they've been doing the dots, and they were able to engage persons from the community, like nurses at the health center, support the DOT strategy, and they were able to maintain over 80% treatment success rate, and where other regions are still struggling. Now, one advantage is because Region 10 has a dense population in a smaller area, and there are other regions with far-flung, areas and difficult terrains and all these different things. But each region, we would like them to, they have to work with different initiatives to come to actually, you detect the cases and you have to work with the patients to cure the patients. Because TB is curable, it's treatable and curable. And I would like to see other regions, taking serious, steps forward. However, I'm pleased to say that with World TB Day observed last Friday, 24th of March, under the theme, Yes, We Can End TB, all the regions participated in their own activities. And this is a good thing because, COVID overshadowing us for a bit and, persons coming up, hyped up with the theme, Yes, We Can End TB, is really a good thing to note and see that these regions are actually stepping up the game. So we have different activities that the regions undertook, and that will be highlighted. I must say that there are some good news for persons, the TB fraternity around the world, because the DOT strategy we're using to observe persons taking their pills to ensure that they're compliant and using medication. We were using medications for a long time, over 50 years, the same regimen of 4-drug therapy, and that is for 6 months for TB susceptible cases. That's the new cases, and we actually have a new regimen recently came out that entails the use of rifapentine and moxifloxacin, and you can achieve the same as the 6-month therapy with just treatment for 4 months. So we're hoping to introduce that regimen by 2024, and the patients will just take 4 months instead of 6 months to be cured, and that will actually decrease some of the burden, like persons to go and work with them and the pill burden and so with patients, because sometimes you have patients who are having other conditions like HIV, co-infected with HIV and so. And on that note, we've also seen the decrease in the incidence in the co-infection of TB and HIV over the years. When we've had, in 2012, 32% co-infection rate, last year we just had 16% of co-infection rate. So it's actually halved, and we continue to work together with our colleagues from the HIV program. There are a lot of work to do, but over the years we've actually managed to drop the burden of TB HIV co-infection with a lot of prevention, and we still need to do more, because, and on a note with prevention, we have new medications to introduce in the country for latent TB infection. We've actually received a combination pill of rifapentine and isoniazid, which will be rolled out soon, and that will decrease the pill burdens also, because to treat latent TB infection, currently we're using isoniazid for 6 months, daily for 6 months. And with this combination, new combination that we'll be launching soon, we will be giving the patients once a week for 12 weeks. All right? So that's half the time and only once a week regimen. So that is something good that we're looking forward to. And in terms of multi-drug resistant TB, it is difficult. We've had 5 cases detected last year, but it's difficult to use a regimen of 18 months to 2 years with patients. Sometimes patients are substance misusers, from that poor socioeconomic background. Also, patients have posed a lot of challenge to be compliant. So for treatment of multi-drug resistant TB, current regimen takes 18 months to 2 years, and that can really be difficult managing patients for that long. Also, the support system that is needed because most of our patients are from low socioeconomic backgrounds. So that kind of, pose a major challenge because TB is linked to poverty, and we see these things in, where the persons are from and how the daily existence, and so we still have a lot of struggles with that. So there's a new regimen we hope to roll out next year, a BPAL regimen, which takes 6 months. And hopefully that can see us improving on our treatment success in that group of population also.
There are times when you may have been exposed to the tuberculosis germ, also known as TB. TB is a contagious airborne disease. The main symptom is a persistent cough lasting more than 2 weeks. TB could affect you and your family's health. If you get it, you can pass it on. The good news is, TB is preventable, treatable, and curable. Free screening and treatment is available at TB sites across Guyana, so find out how to be TB free.
There's a disease in our society that anyone can catch, regardless of age, ethnicity, or gender. Symptoms can range from loss of weight and night sweats to a persistent cough lasting more than 2 weeks. Tuberculosis, also called TB, is preventable, treatable, and curable. If you or someone close to you may have caught TB, get screened free at a TB site near you. TB doesn't care who catches it, do you? Be TB free.
Currently, we have 21 sites across the country, all 10 regions, starting from one TB site in the year 2000. And the next site, shortly, we will be starting that at Susdai. The staff are being trained in a community health workers curriculum, and we will be opening that from next month. So we'll have 22 sites across the country. So we were able to roll out services to detect TB and treat TB. The DOT strategy, where we have persons trained to observe persons taking the pills, and so we are looking at training the temporary staff. We got, mandate from minister to utilize these persons also, and they can help us in the regions where you have, the far-flung areas where you don't have the outreach workers, and they can give support. Treatment supporters for DOTS, we embrace that initiative, and we did some training in some regions already, and we hope to boost the DOTS program with that initiative, and still maintaining our DOTS workers in the high burden areas and so, right? Because we need to have our outreach workers as focal points in some regions, because you can have persons who are not compliant and also not having the medications given to them and observed. They can develop resistance. So it's very important for us to have persons observing these people take the medication, be cured of TB. So I must say that with the COVID-19 pandemic, we were able to have some benefits of testing machines like gene export machines. So we were able to roll out gene export technology to seven regions, and by next year we hope to add 2 additional machines to 2 other regions. And very recently we've actually received from a donation 10 optical machine, which this gene export machine is one that can test for isoniazid and 5 second-line drugs, TB meds. So this is a boost for us for diagnosing drug-resistant cases, and we've started to use it, and these are big pluses for the program with using the new technology, where you can get a test in actually two hours, right? A TB test. So I must say that we are on the trajectory to reduce the incidence and also to eliminate TB by 2030. However, we can do with some additional resources, and there's where we need to keep getting the political commitment that is necessary. There are different struggles from time to time with human resources and also transportation resources and these things, but we can do it. We can end TB. So you find that our patients, they have a lot of social issues, socioeconomic, because of the background and so. So we try to give them the much needed support, right? So we have an enabler support program where we give a hamper. We also get for co-infected patients support from the HIV program, the food bank there. We also give Supplygen right across the country to the key population, or patients, even in the prison or TB patients, we send Supplygen for them, and they have, and different things to boost them. They have vitamins and all these different things to boost them, their immune system, and help them to recover. The rate as we need to see them recover from TB. Also, we had support from a project to give some hot meals periodically. And now we've absorbed it, and the ministry, I'm thankful that the ministry is supporting those patients that are very, very needy, and they welcome the hot meals. And that is actually keeping some of these patients on the medication, because they look forward and they come to you, and we were able to give them that. And these are some of the things we try to keep them on treatment with. And we are a producing nation, so we want to see further, like for example, the social support given, where one of the goals is actually to decrease catastrophic costs to patients and their families. Important goal other than incidence and mortality. One of the NTB strategy, the goals of that strategy is to decrease, or no family should have catastrophic costs. So although there established avenues where you can get public assistance and so, these take some time to process. And remember, TB is just you're treated for at least 6 months, right? More or less. So we're working to see how, more support can be given, maybe a cash voucher we would like to see in the near future for patients to help them. Since, even our economy is going up, these are things that countries can do, at our level. Identify the very poor person, and TB is linked to poverty. Identify these patients and give them the support. So these are things we're hoping to, we're advocating and, trying to see how different agencies can work with us. So that is important to keep the patients, because as the incidence is coming down, mortality is also coming down. In 2012, we had a mortality of 12 per 100,000. Last year was 1.7 per 100,000. And that is, it's really good for us. And even in the mortality in the TB HIV group has actually reduced. So this is actually something good for us as achievement, but we actually want to see this mortality go right down, because TB is preventable, treatable, and curable. We don't need to see any of our patients dying from TB. Once they're detected, put on the appropriate regimen and have them cured.
It's indeed a privilege to be having this interview, marking our anniversary, World TB Day, our 19th year. For me, I'm 19 years with the TB program. I'm one of the TB field supervisor attached to Central Georgia. Being here has been quite an experience for me. They've been good and they've been bad, but one of the joy and the takeaway and the motivation for me is to see our patient move from one stage to another. Clinically, you would see them walk through the door close to death. And as we start giving care, where I come in, the DOTS program. DOTS simply stands for Directly Observed Treatment Short Course. That's where we see our patient take their medication daily. The DOTS program also is one of the most effective strategies that is being used in the TB program. DOTS has a holistic approach. We have steps that we walk our patient through. The first step would be as they come to us, and the first service that we provide for our patient is that we would have the interviewers to find out the reason why they're here. And as we interview them, we will know if it's a contact, if it's a new patient, if it's a referral, whatever category of patient we're dealing with. And that is where we will offer the service. The service that we have here to offer, the first thing will be, we either order the sputum test, the TB skin test, which is the tuberculosis skin test, and we also offer an X-ray for our patient. When that is being done, then this is where our physician come in, where they would examine the results and determine what category of patient we are dealing with. For the DOTS program, our focus is on the TB disease. When we say TB disease, we're talking about persons who were diagnosed with TB. Clinically, they're sick. And after we would have been assigned to that patient, we also would focus on the contacts, because one of our objectives is to stop TB at that patient level. And the contact, we basically would focus on screening each and every family member by having them do a sputum test and a chest X-ray to make sure that when that patient is finished, there's nobody else in the home we're dealing with TB. We also have quite a lot going on for us at the DOTS program. This is where we actually would go through the step of walking the patient through a counseling session to help them understand what they're dealing with is not the end of life. We also would need to empower them, because we find TB affects the category of poverty, as you find the homeless. So sometimes we have quite a lot of work to do. And for the DOTS program and the DOTS worker, they can speak. For me, it's been, as I said, quite a number of experiences, the good and the bad. Because sometimes, especially if the patient is coming from the street, they become your patient and your family member. So you're looking after transportation, meal, and all these different things if the program is not offering it. So it's quite a lot that happened with the DOTS program. Along with that, what you have going for the DOTS program now, since the pandemic, we would have been affected tremendously. So now we're not doing DOTS per se. What we're doing is weekly visit, but we're incorporating treatment supporter. That is where we will actually have a family member, and we will educate the entire family, but then we will focus on somebody who we know that can support this patient, get them to understand. Along with the education, we will even care for that patient. Because some persons, and let me tell you, TB has a stigma to it. As we know, the myth out there is once you have TB, you have HIV. It's not the case.
We still see some amount of stigma and discrimination with our patients, and TB has been around for far too long time. We've seen COVID came and we had to make some adjustments. People had to do so much. It's airborne just like TB. It's spread, the COVID virus is spread, just like TB bacteria. But it actually helped using the mask and all these things for the patient. I guess they're comfortable to use their mask. They don't feel, persons looking at them. These are some of the good things that came out of the pandemic. Also, I would like to call out on the families to give the necessary support. TB is curable. Don't treat the patient as if, they have a disease that is not curable, like, Ebola or something. So we don't need to do that. It's 2023. So we need to give the necessary support. Know that you can be screened. You can be screened to see if you were exposed to the germ, and you have prevention. Now we have better prevention. The combination pills once a week for 12 weeks is something good. We really welcome that. We have it in the country. We will start it very soon. So you don't have to be afraid that you're exposed to, to TB bacteria. We've learned so many lessons around the world. We need to learn from this COVID pandemic that we experienced. And, persons should, try not to stigmatize TB patients and give them all the necessary support. TB has been around for far too long. So we really need to have everybody on board so that we can realize the NTB strategy and NTB in our country and globally. So yes, we can NTB, and together we can make the difference. So let's all work together to NTB in Guyana. Thank you.
Thanks for staying tuned with us. I'm your host, Alicia Martin, saying goodbye for now.